Hello again.
Good girl. Good
Oh,
job.
okay, so we're gonna pick up here. Thank you. Okay, are you able to see my screen? Okay. Okay, so I left off the with reliability. The reliability of testing results can be compromised by the procedures used for sample collection. One significant issue arises from the involvement of nurses' aides in collecting urine samples. It has been observed that many nurse aides may not have adequate training or understanding of the critical steps required to obtain a clean urine sample, which affects the reliability of these results. For example, proper collection techniques typically involve instructing patients to first clean the genital area with a cleansing wipe, partially void into the toilet to flush out contaminants and then collect the midstream sample. Unfortunately, a lack of proper training may lead to some aides to skip these important steps, instead instructing patients to simply provide a urine sample without any cleansing or preliminary voiding. This oversight can result in the introduction of bacteria or other contaminants into the sample, ultimately affecting the accuracy of the culture of results, leading to false data about infection rates. Moreover, reliability can be further compromised by human error during data entry into the EHR system. Instances may occur where data is incorrectly logged, such as entering data under an incorrect time frame or misclassing or even misclassifying a urine sample as clear when it should have been documented as cloudy. Such inaccuracies not only affect patient care, but also distort the overall data reporting used for CAUTI tracking and prevention measures. To enhance data reliability, it is essential to utilize reputable sources for data collection, including infection control databases such as the Centers for Disease Control and Prevention, the Centers for Medicare and Medicaid Services, and the National Healthcare Safety Network. These organizations maintain rigorous standards for data collection and reporting, ensuring that information is accurate and up to date. In qualitative research, employing standardized survey questionnaires can significantly improve the reliability of data collection. The Jochen and Vaughn in 2019 emphasized that semi-structured interviews are partially valuable in healthcare services research. This method allows for the gathering of rich, open-ended data, thus enabling researchers to delve deeply into participants' thoughts, feelings, and beliefs about specific health issues, including their experiences related to COTIs. The validity of instruments, tools, surveys, and questionnaires is paramount. It is directly influent as it directly influences the quality of the data collected. To ensure that these instruments are effective, it is crucial that they are specifically designed for healthcare professionals, ideally with ideally by those within the healthcare field who understand the nuances of patient care. Surveys and questionnaires should be constructed based on foundational work conducted by experts in the field, providing a strong theoretical framework. For instance, the Watson's theory of caring, which was developed by a nurse for nurses, has been widely adopted as a guiding framework for nursing care across various practice settings for several decades. Obtaining precise laboratory data and measurements is essential for researchers seeking to generate quantitative data that can be used to track trends related to infection rates. Laboratory tests such as complete blood counts and urine analysis are vital for identifying the presence of infections and bacteria. Furthermore, established play sort database sources play a crucial role and delivering accurate information regarding CAUTI rates and compliance metrics as they regularly are updated to reflect the latest available data. This precise and timely information is instrumental for healthcare providers in developing and implementing infection control measures aimed at reducing the incidence of CAUTIs in the healthcare field. Okay. Now to implementing and planning. To effectively implement my quality improvement initiative within the organization, Rivera and Fitzpatrick advocate for adherence to a systematic process foundational to its success. The initial step involves identifying and engaging key stakeholders to constitute the evidence-based practice change team. Stakeholders are defined as any group or individual who can affect or is affected by the achievement of the organization objectives. Engaging stakeholders in the formulation of the implementation plan is crucial, as their involvement significantly enhances the likelihood of securing their support for the proposed changes. The establishment of the evidence-based practice change team will be completed by December 23rd of 2024. The composition of the evidence-based change team should include nurses, specialists from the urology department, quality improvement specialists, clinical and administrative nurse leaders, and nurse researchers, thereby ensuring a comprehensive range of expertise. The team must encompass both clinical experts and mentors in evidence-based practice to facilitate effective guidance throughout the process. Additionally, it is important to consider a catchy phrase to name this project. This ought to create excitement and motivation with the members of the evidence-based practice change team to move forward with project objectives. So as you can see here, my catchy phrase is the acronym ELDER. Eliminate losses, do elders right. In the recruitment of the evidence-based practice change team, it is imperative to acknowledge and address potential barriers for change. Melnick and other authors in 2023 stated that several prominent impediments to the implementation of evidence-based practice changes within the healthcare organization include insufficient evidence-based practice knowledge, the perception that evidence-based practice is time-consuming, and that the belief that evidence-based practices impose an excessive burden. A lack of available evidence-based practice mentors and organizational cultures that are not amenable to evidence-based practices. Furthermore, it is critical to recognize that a subset of nursing staff may exhibit resistance to change. A significant number of nurses currently favor the use of indwelling Foley catheters for the management of urinary retention and ensuring patient comfort. Research conducted by Tucker and other authors in 2023 stated that involved interviews to nurses to identify barriers to implement change. Respondents articulated that although they do support the integration of evidence-based practices in nursing, their heavy workloads and restricted time frames impede this transition. The considerable barrier will be addressed in forthcoming monthly meetings with hospital administrators and nursing directors, which aim to alleviate the workload of nurses, thereby enabling them to achieve optimal patient outcomes. Additionally, educational initiatives designed for nurses, nurse educators, and managers will empower these stakeholders to address the concerns to those reluctant to implement this new methodology. Upon the establishment of the evidence-based practice, what's this? Oh, okay. Upon the establishment of the evidence-based practice change team, the subsequent step involves seeking administrative approval. This step is vital to ensure alignment between the proposed practice change and the organization's overreaching goals and vision, thereby facilitating the project's success and sustainability. Approval may be sought from unit managers, directors, chief nursing officers, or CNOs, and professional governance councils and committees. Okay, so this is a chart to ensure that all members of my evidence-based practice change team are aligned and working towards the same objective. We have adopted the SMART criteria as our guiding framework. The SMART acronym stands for specific, measurable, attainable, relevant, timely, and timely. And these principles will provide clear direction in redefining our objectives. One specific, each objective, one, the first S in the SMART acronym stands for specific. Each objective will be clearly articulated to eliminate any ambiguity, detailing exactly what we aim to accomplish. M stands for measurable. We will establish criteria to quantify our progress and success, allowing us to track our achievements against defined benchmarks. A stands for attainable. Our objectives will be realistic and achievable, taking into account the resources and capabilities of our team, ensuring we stay motivated and focused. R stands for relevant. Every objective will be directly related to our overall goals, ensuring that our efforts contribute meaningfully to the larger mission of our project. And T stands for timely. We will set deadlines for each objective to create a sense of urgency and keep the team accountable, helping us to prioritize our tasks effectively. By implementing the SMART criteria, we will foster a cohesive team environment where everyone is engaged and well informed about our shared goals, ultimately enhancing our ability to drive a meaningful change. Okay. This timeline presented above indicates that an evidence-based practice change team will be formed by December 23rd of 2024. Beginning January 6, 2025, the evidence-based change team will gather in person on the first Monday of each month and will hold virtual Zoom meetings on the third Monday of each month. These meetings will continue for the entire time until 6 months post-implementation of the intervention. By June 30, 2025, the evidence-based practice change team will have allocated all necessary funds for staff education and training, along with the relevant equipment required for the intervention. All training is expected to be completed by October 1st, 2025, and the intervention will fully be implemented across all units within the organization by October 25, 2025. The team will continue to meet monthly and 6 months after the implementation. It will assess the intervention's effectiveness. Okay, the E stands for evaluation in the PEACE model. Outcome measures are regarded as the gold standard for evaluation as they assess key factors such as patient satisfaction, infection rates, length of hospital stays, mortality rates, and cost savings, all of which we aim to accomplish by implementing my project called ELDER, Prevent Cauties and Elderly Project Initiative. These metrics are crucial for determining the overall benefits of an intervention. One approach to measuring outcome measures is through patient-reported outcome measures, or PROMs, developed by the International Consortium for Health Outcome Measurements. PROMs consist of a set of patient-centered outcome measures designed to enhance decision-making at both the individual patient level and within patient groups, ultimately improving quality of care. When choosing the right outcome measure, it's important to determine benchmarks and best practices to assess analyze, and compare the effects of my project. This is typically carried out by comparing my organization's CODI rates to those of similar organizations, specifically at the unit level. Data reveals that RWJBH has a catheter-associated urinary tract infection, standardized infection ratio of 0.671, and that NUR compares to the actual number of CODIs against a national benchmark NUR of 1. This benchmark is derived from extensive data reported to the National Healthcare Safety Network. The National Healthcare Safety Network publishes data at the beginning of each year, reflecting every facility's completed data from the previous year. When evaluating my evidence-based practice intervention, Rivera and Fitzpatrick suggests important concepts that one should ask. First and foremost, I want to evaluate whether the main instrument used to measure outcomes is reliable. The electronic healthcare record is a measurement tool. The EHR facilitates the collection of quantitative data, enabling us to evaluate the effectiveness of the intervention by determining whether they lead to improved patient outcomes, have no effect, or the result in deterioration. The EHR is crucial for monitoring various patient metrics, including pain levels, the number of catheterizations performed, urine analysis, laboratory length, laboratory results, length of hospital stays, antibiotic prescriptions, and physician directives regarding voiding protocols and the use of intermittent catheterizations or indwelling catheters. Although the EHR is valuable in gathering evaluation outcomes, their reliability can be compromised by human error during the data entry. Errors include logging in the data at incorrect times, misclassifying a urine sample as clear instead of cloudy. Such inaccuracies not only affect patient care, but also distort the overall data utilized for tracking and preventing CODIs. Moreover, research shows that EHR-based quality measures may not effectively support quality improvement initiatives. Many organizations lack the technical expertise needed to use their EHRs efficiently and may resort to manually reviewing charts for quality reporting due to lack of trust in EHR-generated quality metrics. Therefore, cross-examining the evidence by auditing will be sufficient in this case. The objectives of my quality improvement project is to provide evidence that enhances patient outcomes within my organization. Thus, it is essential that my project intervention is sustainable. As the evidence-based practice change team will meet 6 months after the intervention's implementation, it is important to have a strategy for maintaining the change in the event of successful outcomes. To ensure lasting improvement, I will implement the Plan, Do, Study Act framework. According to Elliott 2024, the Plan, Do, Study Act process begins with delineating a plan for executing the quality improvement change. This is followed by implementing the plan to achieve improved patient outcomes. After implementation of the effectiveness of the change is evaluated, and finally, revisions are made to further enhance outcomes, thereby increasing the likelihood of sustained change. Moreover, Rivera and Fitzpatrick present the PDSA model as a cyclical process that fosters sustainability, in which nurses develop small tests of change and determine the data they will collect. They implement the change, analyze the resulting data to identify what was effective and what was not, refine the change based on these insights, and repeat the cycle to reassess the impact of the adjustments made. Okay. What's one approach for disseminating my quality improvement project knowledge in healthcare settings is to deliver an oral presentation at a conference tailored to a specific audience, which may include nurses, nurse practitioners, primary care physicians, urologists, and organizational stakeholders. It is essential to consider both small and large conferences. Large conferences typically cover broader topics, while smaller conferences focus on specific fields. To enhance the likelihood of my abstract being accepted, I will submit it for both an oral and a poster presentation to the American Nurses Association. A poster presentation allows for visual elements such as tables, figures, and images, which help convey information effectively while conserving space. Additionally, I can even include a QR code on the poster that directs the audience to a separate presentation. However, a limitation of the poster format is the constrained amount of space available. An oral presentation offers the opportunity to utilize both voice and body language to communicate my message effectively. A well-coordinated delivery enables me to guide the audience through my findings, engaging them with my physical demeanor as well as the information on my slides. Key elements such as posture, eye contact, and hand gestures are essential for maintaining audience engagement throughout my presentation. One challenge of oral presentation is the temptation to read directly from the slides. And I must also, excuse me. Oh gosh. Uh,
Bless you.
Thank you. Um, I must also manage my time wisely. Including too much content within a limited time frame can make the presentation feel rushed. Another effective way to share my QI project findings is through peer-reviewed publications. Two, sus- Two suitable journals for submitting my manuscripts are Advances in Nursing Science, or the ANS, and the American Journal of Infection Control. When submitting to the ANS journal, it is crucial to include a statement that elucidates the manuscript's contribution to the nursing field. The American Journal of Infection Control invites original articles that focus on the prevention, monitoring, and control of infections and related complications in healthcare settings in the wider community. Additionally, the American Journal of Infection Control encourages submissions that utilize epi epidemiological principles to mitigate risks for both patients and healthcare professionals. As we traverse the dynamic landscape of the nursing profession, we will inevitably encounter changes in our careers. Significant transformations in healthcare have emerged, particularly in the wake of the implementation of electronic healthcare records, the COVID-19 pandemic, and the expansion of telehealth services. As nurses, it is vital for us to remain vigilant regarding new research and to embrace an open mind approach to implementing changes, thus positioning ourselves as leaders who can ensure that patients receive the best possible care. As I move as I move forward, I will actively participate in ongoing efforts to stay informed about my current research. I plan to explore the resources available through the International Academy of Nursing Editors, INANE website, which provides access to a diverse array of nursing-related journals on the topics of interest to me. Additionally, I will engage with the materials offered by the American Nursing Association, to which I subscribe, in order to remain updated on the latest research, clinical trials, and best practices within the field. Involvement in nursing committees, which I am actually part of the Quality Improvement Nursing Committee in my organization, participating in continuing education courses, attending conferences and webinars, and utilizing social media will also be crucial strategies for staying current within the latest advances in clinical practices. And these two pages reflect my references used throughout my project. Thank you very much for coming to my Capstone 2 oral presentation. Um, Dr. Grust, I welcome. you to ask any questions you may have. Thank you for
I, this was amazing. You can stop recording. You can stop recording now.
attending. Okay, stop share. Sorry, that little screen, I don't know if you saw that little screen that popped up before. That was just saying that because it like converts the recording into a PDF or something, and not a PDF,
Okay.
like an audio. So I will be able to upload the audio after we're done here.
Okay. So stop recording if you would. No.
Let me see. You were recording. Oh, okay. I'm not.
It's
Oh, okay. Pause.